Good day, ladies and gentlemen, for today's lecture in the online curriculum A to Z in Implant Dentistry. My name is Sascha Jovanovic. Today's lecture will be concentrating on anterior implant placement and specifically on multiple teeth, which as well from a surgical, from a restorative, as well as from a biological has considerations which we have to follow. This lecture will follow nicely the lecture which has been recorded on the basis of anterior implant placement for single teeth. Now, first of all, we look at the classical indications. These multiple teeth in the anterior implant placement, of course, always compared to like what we have with patients with fully edentulous patients. Now, most of our patients where we do multiple teeth are somewhat in the younger to middle age group. This compares to the fully edentulous patients, which usually are the elderly patients who have lost teeth, either through their long-term use of teeth, disease, or trauma. But patients which have multiple teeth missing, maybe 2, 3, or 4, can be younger. Younger to maybe middle age. Just depends how their healthcare was, how their dental IQ was. One area which we have to consider, which is very important, is when we think about anterior implant placement for multiple teeth, very often we need advanced indications because we're looking for anterior implant placement. That usually means aesthetics. We're looking for optimal contour because it's multiple teeth, so we need some tissue replacement. So we're looking at grafting. And often we also need some soft tissue. So these parts are similar to single teeth, but even more for multiple teeth because as soon as multiple teeth are missing, more bone and more soft tissue is lost. I would like to remind you again, and this is like very important, and here you can see now right away, 2 anterior implant treatments done for 2 different patients. The one patient on the left-hand side has 2 implants placed for 2 missing central incisors. The patient on the right-hand side had a trauma with which she lost 4 teeth, and these 4 teeth were replaced with 4 implants and a bridge. Please notice that in both indications, you're looking at the gingival level as being too apical, too high. You're looking, if you would see the x-ray, at bone loss due to like an inappropriate implant position and insufficient amount of bone being present. And concurrently with this, we're seeing gingival loss and gingival pocketing. So to counter these failures, and I see unfortunately quite a few of those in my practice in Los Angeles, is that we have to then go back to sometimes extreme measures by removing these implants. And then go back again to the original level of the ridge, and then you can see here that we have removed the implants through a surgical procedure. We have now taken off the bridge, and we have to start over again. But beautifully demonstrated now here is these are multiple teeth missing in the anterior, and you can see already just by looking clinically that there's a big gap in this area. A lot of tissue is lost, a lot of bone is lost, so this really is a problem for this patient. So to redo this here, we have to graft bone, we have to add soft tissue, and then we can do implants. Now, we know the results for single teeth. We know the results for multiple teeth. The partially edentulous are not different. So from a functional standpoint, they do very well. So you can easily comfort yourself, like I do with my patients, by telling them the evidence in the literature is strong. We have 95+ percentile for 5, 10, even 20 years of results. So this is a long-term treatment. The only problem, again, is aesthetics. So we're focusing right now on anterior, so we want to focus on aesthetics. And this is important for us to do because the results with aesthetics are often compromised if we don't follow criteria which really have to do with immediate or optimal implant position. In this particular case, you can see here the good aesthetic result on a patient who had here 1 implant placed in a central incisor. Now, what are the criteria, again, for often rejection for treatment or limitation in treatment? And the main reason really has to do with anatomy. So anatomy is often limited, and limited in multiple teeth comes more frequently than single teeth, because what you see is that when single teeth gaps are available or seen, the adjacent teeth often are the ones who are maintaining the bone and are maintaining the soft tissue. So that's important to see. So we're looking at this here really as multiple teeth can have a problem even with more anatomy. So we have to focus on diagnosing these patients very well, how much bone is available, how much soft tissue is available, and then we can offer the patient a treatment plan which is correct. Because here you can see already that this single tooth implant doesn't really have a good aesthetic result, as it has this high gingival margin, so a long crown. So let's focus now on implant position then. And this is similar to single teeth, but it has an additional touch to it, and I'll bring that forward in a moment. I'll summarize again what we discussed for single teeth. This is where we're going to be focusing on. The total soft tissue height again is plus minus 3 millimeters. So when I place one implant or I place multiple implants, there's no difference in how I place the implant in a vertical position. So my gingival margin is my goal. My bone height is my goal. And this here basically means that I have, in this height here, 3 millimeters available. So the implant position will always end up between 2 to 3 millimeters when I compare the gingival margin, the ideal gingival margin, to the implant neck. So this doesn't change, single or multiple. The distance between the implant neck and the tooth doesn't change. It's always about 2 millimeters. So wherever the implant is close to a natural tooth, we're going to maintain about 2 millimeters. The buccolingual dimension doesn't change. We're going to go about 2 to 3 millimeters lingual from the contour of the tooth. So our goal is basically to maintain a thickness of bone on the buccal of an implant, which is about 2 millimeters. And this will allow us then to have a result, which is good. So how do we compare the single teeth and to the multiple teeth? Well, it's right here. And I'm going to be concentrating on this level here. You're looking at one area which is very particularly difficult for multiple teeth. And that is to focus on the bone which is apparent between two implants, right here. This is what we call the inter-implant bone papilla. The space between two implants is the only thing we have today really which can help us to preserve good soft tissue or good gingiva. So therefore you can see here that Tarnow and Salama in the past years have brought out some evidence which demonstrates to us that the distance between two implants need to be increased to about 3 to 4 millimeters. And you can see that very well demonstrated in this particular case, where two implants were treating or replacing two failing center incisors. And the distance between the two implants has been increased to about 3 to 4 millimeters. Therefore, as you can see, the bone level is high if you compare it to where the bone attaches to the implants. And in this way, we can actually increase the bone height. And if we can increase that with about, let's say, 2 millimeters, that gives us already a good aesthetic gingival papilla. At least one with the patient and the doctor can be happy with. The more we can increase it, the better it is, of course, because in tapered teeth, it can give us more gingival tissue. Now it's important to realize that this interproximal bone papilla is unsupported. So the only thing which supports it is actually the thickness of bone. Therefore, we need to have a lot of bone, and we need to also have sufficient distance. So bone needs to be maintained or respected or grafted. And the space between implants will maintain it. Now that's really the main point where the difference is between a multiple teeth with single teeth. Now we come into another area, and this is pontics. This particular patient we treated many years ago, about 10 plus years ago at my clinic at UCLA. And you can actually see here how this was a 6-unit prosthetic restoration with 3 pontics. And to counter the problem of 2 implants next to each other and the problem with the gingival papilla, what we do today for implants is that we use some of the good advantages and results of traditional prosthodontics. And you can see here that pontics can really give this full gingival emergence. They can even give an aesthetic illusion of having a papilla there. Although there's no implant, there's no tooth there, nothing. It's just a restoration. And we're going to be using this in implants today, if we have the chance, to bridge aesthetic areas where more than two teeth are missing, to give the illusion of a gingival profile. So as an example, if we have 3 teeth missing, we'll place 2 implants with 1 pontic in between. That usually gives us more control over the aesthetic result than when we place 3 implants next to each other. Okay? And we're going to now look at some of these treatments in the particular patient presentation. So first of all, I always look at diagnostics. And when I have bone missing, I'll do my diagnostic wax up really well, so I know exactly how much bone I need to graft. And I look at the gingival biotype, that I know how much soft tissue I have to really advance or transplant. So rebuilding of the physiological anatomy is important for me, because usually when multiple teeth are missing, you can see already this is the papilla height, but it flattens out. So this is quite a typical view for a ridge. So you want to thicken it, and you want to heighten it. Very important. And for that purpose, I use bone regeneration. I use the concept of membranes protecting the site, separating the bone graft from the flap, from the bacteria, and I use the concept of guided tissue regeneration. New treatment options are emerging, and specifically looking at growth factors. But today we still use very much the treatment of guided tissue regeneration. So for these particular cases, especially in the anterior implant placement treatment, the punch technique, as I showed it to you in the single teeth, is not very often used. As we need to see the bone ridge, and we need to raise a flap. So the 2 treatments which I use from a flap standpoint is really raising a papilla preservation flap, as you can see in the left picture on the screen, or a remote flap design, which you can see on the right side of the screen. And most often I'll use the remote flap design because it gives me more flexibility for treatment, it gives me more potential to place a bone graft, and it allows me more surgical control to close the flap. So the remote flap design is my major treatment option which I do here. Now you can see here the first treatment option. A patient, middle-aged, had lost the 4 anterior teeth to some disease, periodontal disease, and is left with a large gap and had a removable partial denture. So the treatment option here was placing 4 implants to give him 4 single crowns, but I have a problem with the aesthetic outcome. So my optimal treatment, as you'll see in a moment, would really be 2 implants with a 4-unit crown, a 4-unit bridge. But in this particular patient, because of a slightly increased amount of occlusal habits which the patient had created, and not wanting to go through a full mouth rehabilitation, we treatment plan the patient with a night guard for the long term, and 3 implants to be stronger in the front. But you can see immediately how the gingival profile here is thicker, and how between the 2 teeth, between the 2 implants, it's reduced. And from evidence in the literature, we can say that the gingival papilla between 2 implants can create about 3 millimeters of height. And when we look at the gingival papilla between an implant and a pontic, it's about 5 millimeters. So that's quite a difference. So the pontic has an advantage. And here you can see the creation of the pontic in the temporary ridge. And you can see actually how nicely we were able to demonstrate here this gingival papilla. So this is quite a beautiful result here for this patient. And we were able to recreate here this gingival papilla for the patient with using an implant next to a pontic. Yes, it is important for these kind of cases for the ovate pontic to create soft tissue. So here often we have to utilize some soft tissue graft to augment the site, to plump it out, to augment it. And then we can place the pontic right into the site as an ovate pontic to push it out. But here you can see the keratinized tissue maintenance and the soft tissue maintenance. Here the view of the radiograph. Notice the different height of bone. You can see here the height of bone here, and you can see the height of bone here. So the different layers. And that is very clearly showing already how maintain more bone when we have a pontic. And here the 4-unit bridge demonstrated here in the anterior, showing you how nicely the ovate pontic emerges from the tissue and still giving that good aesthetic result. So this is possible for patients like this, and it gives us a good option to get still anterior implant rehabilitations, but with a good aesthetic result. Now I would like to demonstrate to you the other treatment option, which I think is good. Here's a patient which was elderly. She was past the 60 years and had these 3 teeth still present, but with root canals and posts. And after some fractures, a treatment plan came up to look at retreating this patient with a 4-unit bridge, traditional. But the dentist saw that there was not enough root or tooth structure available, was not able to restore this, unless again going through root canals and posts. With these short roots, it was not a viable option, and implants came into discussion. So now we can see how we can actually remove these teeth and place only 2 implants in the lateral 2 positions and do pontics for the centrals. And I still end up with a solid 4-unit bridge with a long-term result. So here's the treatment. You can see here the surgical guide stent, which is helping us to place the implants in the optimal position. You can see how in the 2 central incisor areas, bone graft material is utilized to augment the site with the purpose to have more foundation for the pontics. And the 2 implants also had some bone deficiency, so they were grafted as well to thicken the bone. Now you can see the ridge recreated here at the top photo. And you can see how the 2 implants in the lateral incisor are submerged and the central incisor area is augmented. This particular case, because of the bone graft, we waited for about 6 months. And at 6 months, we're coming back with an uncovering procedure which will bring keratinized and thick soft tissue to the buccal. And it's going to expose the buccal area where we can either review the bone, the implant, or remove materials like here, membranes and bone tacks, titanium bone tacks. This allows us then, if necessary, in this particular case here, to review if there is sufficient soft tissue available and present. And here I added, in this particular case, at the uncovering stage, another soft tissue graft. So I diagnosed that, in my opinion, there was not enough thickness. And to create a good emergence profile, I need more thickness. And interesting here, I harvested this piece of soft tissue, it's right here, from the palate. I placed it into the buccal pouch, like in a tunnel, and I used these sutures here at the apical area to anchor the connective tissue graft so it doesn't slip around. So these two sutures here were used to anchor the connective tissue at the apex, so I can stretch it and I can place it exactly where it needs to be, and it can then allow this area, as you can see, to get extra tissue in the front. So I'm using connective tissue purely to augment the ridge for emergence profile. And now you can see how I'm able to utilize an ovipontic design of the bridge to actually bulk out soft tissue and to get this kind of creation. So this is really nice, and it allows me really to develop a good ridge. So this is good from a standpoint of soft tissue augmentation, as well as from a standpoint of creating an emergence profile for the bridge. Other areas have to be looked at always in the same fashion. So when we have another patient like here, this patient was middle-aged, about 40, but had periodontal disease in the history. And what you can see here is 2 central incisors and 2 lateral incisors with thin gingival biotype, with a frenulum pool. And these 4 anterior teeth are missing or are failing. And the first thing to evaluate then is really, when we look at this here, how good are we going to be in the grafting procedure? I'm going to place here 2 implants in the lateral incisor, but I want to increase my chances for success with the grafting procedure. So what I'll do first is I'm going to remove these teeth. I can then just let the soft tissue granulate in. I come back 6 weeks later. And 6 weeks later, I'm going to be grafting this here with bone, with implants, and you can have a result like this. So now the 2 implants have been placed, as you can see, in the lateral incisor area. We have the 2 pontics now available for the incisors, central incisors. And we can also now develop a good ridge because of this soft tissue which we have allowed to heal in the first 6 weeks. So this is a delayed extraction site. You can see it beautifully, how the bone was regenerated, how the ridge was augmented, and this was done with a particulate bone graft, and this was done with a membrane, and at this moment you're looking at the result after 6 months of bone healing and at the stage of uncovering. So the sequence of event was here. Patient arrived with failing teeth. We removed the teeth. We waited 6 weeks. We placed the 2 implants with the bone graft. Waited for 6 months, and right now you're looking at the uncovering stage. Now we're ready for restorations, and as you can see here, the restorations can be done in such a way that we can actually really beautifully now create an emergence profile a 4-unit bridge with center incisors and a cemented restoration. And here you can see the result in this particular patient with a 4-unit cemented restoration. Now it looks like that this patient has a little bit of an loss of tissue, because you can see the longer teeth, but it actually fits with her overall teeth, because if you look at also the lower teeth, you can see that she has lost throughout the whole mouth periodontal attachment. So it is not the most ideal aesthetic result as we would like it, but it matches the rest of her teeth. So this still is the way we would like to treat it. 2 teeth, 4-unit bridge, better than 3 implants or 4 implants. And this patient was lucky. You can see here, this is a low smile line. The smile line on this particular patient is about, showing about half of the teeth, and does not demonstrate the aesthetic compromise because of the periodontal loss of attachment. So we're actually quite happy in this particular patient, because we can give her a good, stable, functional rehabilitation, good ceramics for her smile, and still healthy solution. Now I go to a more difficult area, and this will give you now a combination of an aesthetic and a functional rehabilitation. This patient again was elderly. She was like 60 plus, and she was wearing a removable partial denture, and she had 3 to 4 teeth remaining in her upper jaw. Through the advent and the evidence we have with implants, she came now to the office and asking for, how can I have some fixed teeth? Well, multiple teeth are missing, as you can see. It's 2 molars, premolars, and the whole anterior ridge. So we're going to treatment plan her now for multiple implants. But interesting enough, first of all, we're going to do this staggered approach. And the staggered approach means that in the anterior, we're building in pontics for aesthetic reasons. And in the posterior, from distal of the canine, we're going to place implant for teeth so we have more stable function. So this particular patient will be a combination of anterior and posterior treatment. And you can see that because you can see here 1 implant, lateral incisor, 2 implant, then a pontic. So the treatment plan is here, pontic, implant again, then a pontic, and then 3 implants in the back, because we need this for the functional, the forces which are applied here. So the only area which we have a problem still is between the lateral incisor and the center incisor, but here I just needed some more support here to go across the curve. Of course, also it makes a little bit of a difference. As you can see, where do I place the implants? So I have the maximum amount of bone, because I don't want to do too much surgery, especially not in an elderly patient. So sometimes you move the implants. That's why we need a surgical guide stent according to the bone available. So we're going to try to do as little as possible bone grafting necessary, depending on the amount of bone which is there, and then we can shift the implants a little bit. This particular patient received in the posterior a sinus graft, which was giving bone, particularly on the 2 molars. Here you can see the final implant position with good bone in the crest, but some bone missing in the apical area. So there you can see how the implants are perforating the jaw, and these particular perforations and the dehiscence of the bone will be treated now with bone grafts and membranes. So you can see that here. And of course, the patients who don't need this are very lucky, because we can place the implants in an ideal position, and we can then go forward with the healing period for osseointegration, or sometimes even with an immediate loading concept. So here we are, now ready for healing, and here's the overall treatment. A total of 6 implants, a total of 1 sinus graft, 3 implants with bone grafts. So this is quite an extensive treatment, all done simultaneously, but a maximum benefit for the patient because we place implants, sinus, and ridge augmentation all at the same time. Patient now can go through healing. You can see here how this particular area will heal uneventfully now for the next 6 months. And we're going to be allowing this uneventful healing to continue without the removable partial denture the patient wears as a temporary for a maximum amount of time, as much as the patient allows. Because pressure will always put some compromise on the healing. And soft reline, recontouring is necessary. What you see in the top right photo is a decision which was made prior to the uncovering procedure. And upon analysis here, as we know that we need a lot of soft tissue in the front, we will be thickening the buccal soft tissue with a large soft tissue graft. This is about 4 centimeters of connective tissue. This is not too invasive for the patient because I have removed it right here from the palatal area. So it came from the internal part of the palatal flap. So it actually came from right here on the inside of this flap. And I have to open this to expose the implants. So I'm just going to like actually do like a thinning procedure to harvest this connective tissue. I'm going to flip it around and place it on the buccal, as you can see right here. And this area will allow me now to thicken the buccal side. So this is quite nice because it demonstrates to me almost like a recycling treatment, taking soft tissue from the palate, moving it to the buccal to thicken the area. And as you can see, the healing, once the healing abutments have been placed, is quite well. It incorporates itself in the buccal flap nicely. It revascularizes well. And the sutures are just holding sutures. And here I'm using 6-0 nylon to adapt and approximate the flap. And here the final healing. You can see the palatal area where I removed the connective tissue, normal healing. And you can see the buccal, how I've improved the thickness, have maintained keratinized tissue, and I really have an optimal treatment. One kind of discussion which can be added here is that this restoration is screw retained, and this of course is an option which you can give to the patient, either screw retained or cemented, but I personally prefer, if possible, screw retained in the larger segment. So anything which is maybe larger than 4 teeth, multiple teeth on implants, I probably will go for like screw retained because it gives you more retrievability. And today with the zirconia bridges, you don't even see this difference in color between the metal and the composites because everything is white, so it disappears quite nicely. So screw retained restorations are actually making a comeback today because of course they give the advantage of retrievability. Now I go to multiple teeth, and actually I'm focusing on an edentulous jaw. And I would like to present you here with a solution which I believe is quite nice for patients which are missing all teeth in the maxilla. And the way we handle those is, if possible, we only place implants from the canine to the posterior. And the anterior part of the oral cavity, we don't place implants. And that, as you can see in the x-ray, that means that from the canine to the front, or shown here, there is no implants here. So this area will only be treated with Pontics, and this is a 12-unit bridge. Could be a 6-unit bridge going from canine to canine, if you make it in segments. And the ridge has been augmented, usually with soft tissue grafts only. The advantage of this treatment is that you have no implants there, so aesthetically you can control it. Secondly, often the anterior maxilla has a lot of resorption, so if you want to treat them with implants, you need to graft a lot. So you're doing two things at the same time, improving aesthetics and reducing grafting for the patient. So I think this is a good treatment if possible, and if the occlusion allows this. Now let's go to an area of final consideration, and that is if you need to really do two implants next to each other. And here you can see a patient. She was young, in her mid-20s. She had a problem with an impacted canine, which was surgically removed. And in the course of this surgical removal, quite a lot of bone was lost. And the adjacent teeth were also compromised, and the roots started to resorb. So the central incisor and the first premolar did not have enough root attachment to validate a traditional prosthetic treatment of four-unit bridge. So implants came into discussion. Again, gingival tissue was analyzed. It looks to be thick and abundant. Bone tissue was analyzed, and it was not sufficient available. So from that standpoint, a graft was planned. But for certain patients where it's more difficult, I treat them first with a graft, secondly, after the graft is taken, with implants. And here you can see that. This was a vertical bone regeneration technique to increase vertical height of bone, because the bone was somewhere here, and increase the horizontal width for implant placement. This takes time. This is an advanced bone grafting procedure, and it takes about 9 months. So here is the regeneration of bone. You can see here how I was successful in creating bone height. I was successful in placing two implants now. And please notice the spacing between these implants, because this is an important part of today's multiple implant position. Sometimes it's really too tight. So then we need to do orthodontics first to spread the teeth. Sometimes we need to maybe just say this is a case which we have to reject for implants. Sometimes we can even place one implant and do a pontic of one implant. But that's more questionable and has some controversies. So here you can see how I push the implant as close as I potentially could to the tooth. So this has maybe about 1 millimeter, maybe 1.5 millimeters. Between the two implants, I maintained about 3 millimeters. And here, I have about 1.5 millimeters. But you can see there's no room for error here, and it can be very difficult to place these implants because it's really a couple of tenths of a millimeters make a difference. I place the implants in the optimal implant position. You can see that here. This is the implant neck. This is the gingival margin, which we're trying to create. And so you can see how the implant was placed 2 millimeters below the gingival margin. But now I'm showing titanium surfaces. And I have a problem with the interproximal area not having sufficient tissue between the two implants. So there's a treatment for these type of cases where we can allow grafting to be done with filler materials. And that's what you can see here. This is a pure filler material. It's a xenograft bovine hydroxyapatite, particulated cancellous. And as you can see, I do two things. One is I am covering the titanium surface. I'm increasing the interproximal space between the two implants with tissue. This is artificial tissue, but it's stable. And I'm thickening the buccal bone with a couple of millimeters. To prevent this filler material from migrating and moving around, I place a membrane, and that's what you can see here. But it's a resorbable membrane. And this resorbable membrane will go from the palate cover the implants and the bone graft. It will cross over the crest, and it will cross the bone between the two implants, and it will be moved to the buccal to cover everything. This membrane again will separate the flap from the implants and from the bone. So it will allow this tissue to stabilize. So this is a nice treatment from a standpoint of healing. And you can see then after a certain amount of healing, usually we wait about 6 months, the tissue is sufficient supported that we can place temporary restorations which really can give you quite a nice height of gingival tissue. You can see that. This is replacing the central and the canine. And you can actually see even that the two implant restorations have now more soft tissue than the two natural teeth. And that's really what we want, because there's always going to be some settling, some resorption. So we want to start off with more tissue so we allow the tissue to settle. Now we wait. This temporary phase with the temporary restoration is about 6 months. And you can see here beautifully the X-ray demonstrating to us that this artificial bone material seems to be really supporting the adjacent two implants really well, at least radiographically. And that's of course what we want, because this is a clinical treatment. We want the implants to be well integrated in the regenerated bone, and we want the filler material to support the soft tissue. And that's then what we keep as a final treatment for these kind of cases. So this is an option which is possible to thicken bone, to thicken and support soft tissue by creating some material using artificial material. But it's important to conclude from this patient is that this patient was first treated with a very biological approach of grafting. Secondly, implants were placed, so it was very conservative. But then thirdly, we're augmenting everything with filler material. So no combination of treatments, separated all these steps, and you can see a nice end result. So same as in the lecture about single teeth, I will complete here and finish the discussion about multiple anterior teeth, about really looking at uncovering procedures. And when we look at uncovering procedures for multiple teeth, again, this is a topic on its own. So there's a lot of discussion which can be had here. I'm going to focus here to really use the example of one patient to demonstrate some of the flexibilities we have. Again, there's two goals we have. First goal is to increase thickness of soft tissue. And secondly, to increase keratinized tissue. So our incisions will always come more from the palate and be pushed over to the buccal, so swing to the buccal, so we can create thickness. Here in this particular case, the patient was treated with 2 implants, replacing 2 center incisors. And you can see here in this particular case how I have created a design of my soft tissue uncovering, which is maintaining these principles, these criteria. I want to have thickness, so I go with my incision more palatal. I want to have keratinized tissue, so I go more palatal. But I want to also have tissue between the implants, because these are multiple implants, so I make like a little papilla. And that's what you can see here. My incision started off here. Then it moved to get me a papilla between the implant and the tooth. Then it creates a little round area to place it and adapt it around an healing abutment. Then I create again a soft tissue papilla for the area between the space between the 2 implants. I create again space for the healing abutment and then the papilla. Now I don't want vertical incisions here because it can show me verticals. So what I'm going to do is I'm going to make the verticals distal of the canine. And the same thing I'll do on the contralateral area, as you can see here. And here's the incision. So this becomes like a curtain of soft tissue, which is moved from the palate all the way to the buccal. And in this way we can have a good flap, we can see what's happening underneath, and we can fill up all the spaces, and we kind of can jumpstart it. Now, I've raised the flap, I'm showing 2 implants, I'm showing good space between the implants, I'm demonstrating that there's good tissue fill between the tooth and the implant and between the 2 implants. And when I place my soft tissue flap back, you can see actually how it has a tendency to really fill this up. And that's really the concept in these patients, that we have an opportunity really to fill up the site with soft tissue. Now, if you need to add a soft tissue graft to thicken it even more, you can, because it will just be underneath the flap, on top of the bone, and then the flap is closed. So this is to kind of finish off and conclude that when you think about multiple implants, you also have to think about this type of procedure. And here you can see the way it started. We had a block graft here on the left x-ray, placed the 2 implants. On the 3rd x-ray on the right side here, you can see the interproximal bone peak, maintaining it nicely. Here's the heights of bone difference. And then here's the loading and the healing of the soft tissue. So quite nicely shown here how you can develop for patients sufficient soft tissue height, sufficient thickness, and create also a space which is positive. So in summary, I would like to conclude here that many of the criteria which we're using for single teeth are very similar for multiple teeth. And the main compromise we have in multiple teeth is, A, we are missing usually more bone, so we need to be better to create the foundation. So that's an area which we have to be careful with. The second problem we have with multiple implants is that the 3-dimensional implant position is often compromised because spacing. Often we don't have enough space to place the implant. So we need to really diagnostically really measure it very carefully. And the solution we have here is to introduce Pontics. So that's a very nice solution, which of course is not possible for 2 implants or for 2 teeth, but for more than 2 teeth it's possible. The third problem we have here, more than single teeth, is the soft tissue. If you introduce Pontics, you need more soft tissue. So soft tissue grafting is more needed for multiple teeth than it's really for single teeth, because we want to thicken that soft tissue. Now, soft tissue contouring is also more problematic with multiple teeth, because you need to be very careful in managing the papillae between the 2 implants, also with a Pontic. So you have to have some experience with contouring a Pontics for emergence profile. And then the final, which is really the aesthetic treatment with restorations, that of course falls in traditional prosthodontics. We're doing multiple teeth, so you make a decision if it's going to be cemented or screw retained. So I hope that with this lecture on multiple teeth, you got insights how to use this and some protocols and some criteria, how to be successful to do this, as well as how to find the limitations in this indication. Thank you very much.